Man, I love that song. It was 2 a.m. talking to my team, and I felt like going out for a run just listening to that song. Welcome back. Another amazing live show coming on. We have a very talented cosmetic dentist. Everybody knows him, Dr. Jason Olitsky. Welcome.
Thank you, Shaheen. Thanks for having me, man.
Oh man,
Appreciate
you're so cool for doing this.
Excited.
So cool for doing this, man. So thank you. Thank you.
You're cool for asking.
Well, listen, I'm going to show you something really cool right now. Tori, come on, asset 3, let's go.
Iconic.
Let's go. All right, now I gotta show me what you got.
That was amazing.
Show me what you got.
I'll be a freakazoid. Come on and wind me up.
You again down. I don't even know how to do that, dude. I'm just telling you,
I'm into it. I'm into it now. This is good.
Get on the ground and spin, dude. Come on. That was so cool, man. I love the talent all around, bro.
Just give me the chance to break out my 80s, 90s dancing.
I got you, man. No, man, I appreciate this. CEO of Smile Stylist Training Center. I want to talk about this. I've been wanting to talk about this for a while. I've been talking to surgeons, talking about blood and yomis and XNAV and, implant failures and all this kind of stuff. Now I want to get into stuff that I'm going to enjoy talking about a little bit more. Before we do that, though, I got a message from someone. So I want you to think about this. A little trivia for you, Jason. Okay. Ready?
Okay.
All right.
Yeah.
Hold on. I got to get my old man's glasses on so I can read this. So I got a message. Tell me who this person is. Olitsky and his wife were in the first Hornbrook group hands-on program that I taught in Louisville in 2004. Hold on. I wasn't their mentor, but I worked with a doc in the op right next to theirs. Jason and Colleen, your wife, were so funny. Every hour or so, they would take a break from their case and would start making out right there in the clinic. Who was that?
You're talking about a little PDA there. I'm sure you're not talking about make it out. Okay, so I have a hunch. First of all, you were breaking up during that, but I heard Louisville and I heard make it out. So I have some guesses. And I would say because you had Jim Arnold on your podcast, I'm going to go Jim Arnold.
That's so good, dude. That's so good. I love it. Good memory, man.
I got it.
Were you guys making out, dude?
He was there. He was one of the clinical faculty with the Hornbrook group. I cannot confirm nor deny what he has said. Yeah, no comment.
That's awesome. Look,
it's awesome.
Let's talk about this a little bit because I want to just give you a little background of myself because we'll get a little clinical here, and I just want to share this with you as well. I graduated 2001 from Tufts. 2004, I started my journey at LVI, Las Vegas Institute, and I got into it. I loved the cosmetics. Went through their curriculum full mouth. I ended up taking 42 courses, I believe, over about a 10-year period. And back then, 2004, there was a lot of discussion about, smile makeovers and there were a couple of shows on at the time. I can't remember them right now, but
Extreme Makeover.
And it was just
would be like the main one.
Yeah, Extreme Makeover type courses, you know. it was kind of, we can say, what All on X is today. Back in early 2000s, the excitement of everybody wanting to do smile makeovers, but the no prep idea never really presented itself in any of those programs. And I'm intrigued because back then when we were talking with lab techs and, you know, the idea of doing a true no prep was kind of a really an odd discussion. And they would always come back to me and say things like, there's very few patients that are actually the ideal patient for a no prep smile makeover. And so I've always cut teeth. And obviously now I'm very intrigued with, talking to you. How do you diagnose a true no prep case? Can I start with that question? Did I lose you, Jason?
Are you? You're just kind of breaking up quite a bit. I just want to make sure you can hear me. Can you hear me? Okay.
I can.
I'm not sure if you can hear me. I was able to make out some of your, or most of what I think your question was, but I'm not sure that you can hear me.
I can hear you now. Go ahead.
Pretty much. You're frozen, but give me a thumbs up. Okay, cool. So we're talking about no prep. Yeah, I mean, I didn't know really much about no prep when I started doing cosmetic dentistry either. And really the most I knew about no preparation was through Lumineers. And that kind of got a bad rap for what it was. I mean, they did so much marketing around no preparation dentistry in the early 2000s that it turned patients, into, at least their awareness of knowing that something like that exists. And they offered a course that was like a 2-day course on how to do Lumineers. And the results from doing Lumineers really left the teeth looking a little bit bulky, over contoured, sometimes unhealthy. And so the no preparation veneers kind of got a bad name through that part of the process because doctors were really just trying to force all their cases into a no preparation case after taking the courses. But there's a lot more like research and literature behind no preparation porcelain veneers. I mean, we've been doing them for 3 decades. And not until really like Dennis Wells started to focus more on no preparation porcelain veneers and his publishing that he was doing and really refining the techniques of no preparation porcelain veneers that I really start to pay attention to it because I saw his results and they were so good and they're way different than what we were getting through using things like Lumineers. And but for some reason, I didn't pursue it in my practice. For me, it was just like case selection. It's like, do I really have patients in my practice who are going to benefit from no preparation porcelain veneers? Because all the times in like literature articles, you always see these cases as being like people presenting with like peg laterals. And like if you're doing no preparation veneers on peg laterals, that tooth's like already prepped. So that doesn't really count. And so I never really pursued it. And interestingly enough, I started working more with my ceramist I work with now, Juan and Nelson Rigo. And I sent them a case. And when they got the case from me and the photos and everything, they said, you know what? This would be a great case to do no preparation. And that was around 2018. I thought to myself, wow, okay, so I'm interested in this. So let's go ahead and pursue this. And so I did what they asked me to do. I took the impressions and I had delivered at that point a case that was really, really more beautiful, or one of the most beautiful cases that I had ever delivered. And I didn't even touch the teeth. And that was like a game changer for me. It was like eye-opening. It's like, wait a second, for the last, I don't know, like been in practice, 20 years, for almost 20 years being in practice, I had been prepping teeth. And my goal when I opened up practice in 2006 was to have like a cosmetic practice and only do porcelain veneers. And we had gotten that concept through working with Dr. Bill Blatchford. I'm sure you've heard of Bill Blatchford,
Yes.
he's a coach. And he
Yes.
said, you should open up day one, your practice, the way you want your practice to be in 10 years. And so that's what we did. Like day one, we work in 3 days a week. We're only doing smiles. Well, after doing smiles for like 15 or 16 years and really thinking that like we had the perfect practice, I did my first no prep case. I thought to myself, wait a second, what if the next 10 years I focused on trying to create this practice where I only did no preparation, or I did much more no preparation than I had done in the past? Now I was going to be able to do smiles, not drill on the teeth, not to get the patients numb. And it was just a happier experience for me. And so that's what I started more pursuing or focusing in on that no preparation world. Now, is every case no preparation? No, of course not. You got to know when you can no prep, when you can minimally prep. And that's why you were talking about case selection. That's really like the number one thing that we focus on our no prep course at the training center is the case selection for these types of cases. And to answer your question, the number one criteria that you're looking for in doing a no prep case, the patient wants their teeth to be a little bit bigger. If you're trying to do a case where the patient is concerned about their teeth looking a little bit bigger, it's definitely not a no prep case. Those are going to be the toughest no prep cases that you do. So criteria one is definitely patient wants their teeth to be a little bit bigger. I'm sure that makes sense.
Yeah, absolutely. And, you talked about Lumineers, and it brought back that whole bulky discussion as far as, they don't look good. They didn't always stay because the way it was bonded or, placed in. And I remember that whole discussion. But yeah, criteria is really important. And one of the things that we also at some level maybe need to pay a lot of attention to is the lip position, right? Is how they smile and how much teeth they show. I mean, to your point, there's so much there. And it all is pretty intriguing for me, but I want to go to 2018. So you deliver your first case and it's like lights go on, right? It's so look, there's so much to clinical dentistry, but one thing I enjoyed in watching what you do is this brand creation. I mean, you're taking people to the beach. I mean, you're bringing, your patients into your classes. By the way, we'll get into the courses in a little bit, but it's a lot of energy, man.
Yeah, it is.
Yeah. Do you know what I mean? And I can tell you, doctors didn't go to dental school to put that extra energy in. So the challenge in this branding discussion and how do you get these patients, it's not so much just front end lead gen, bring in the cosmetic patient in. It's the aftermath, the during and the aftermath. All of that is so important. Yep. Tell me a little bit about that part of what your every day or every week.
Sure. Yeah. Like. So I kind of refer back to like a visual cycle. It's about attracting the patients, getting them in, building trust through your consults, taking great photos, documenting the case in a way that you can present it to the best of your abilities. And all those things obviously take a lot of time. I say like the easiest cases I do in my office are the ones that I don't take a bunch of photos for presentation purposes, because I'm just delivering a set of veneers, and that's the easiest part of the process. The hardest part is like taking the time necessary to take the proper photos, take the videos and things that you might want to do to present those cases in the future. And so, yeah, it's a big time requirement, and it's a whole lot of, editing, it's, if it's going to be harder, you're not going to do it, and so it comes down to like, how many cameras do I have? Well, you got to have at least 2 cameras. I mean, one with a ring flash for documentation, one with something that's going to give you some nice presentation lighting, because if you have to take the ring flash off every time you want to take something with pretty presentation lighting, chances are you're just not even going to do it, and so it's just like the investment, the time into the equipment, and photography is a big part of it. The interesting thing is like, I had always wanted to get into education. And the first experience that I had is, you heard through Jim Arnold, is I went through the Hornbrook group courses.
Yeah.
And I caught the passion there. And David is very good at being enthusiastic and being passionate about cosmetic dentistry. And he really helped guide me or steer me into education, because I wanted to teach with the Hornbrook group. And when I started teaching with the Hornbrook group, I had to be 5 years out of school to do that. And once I was 5 years out, I submitted a case and they said, okay, you can teach with us. And I wanted to teach smile design. I essentially wanted to teach what David taught, but you're not going to teach what David teaches when David's there. So he said, why don't you focus on photography? The dentistry just needs more photography educators now anyway. And so I became like the course photographer. I take all the photos and I really learned the ins and outs of photography. And I didn't know back then, which is like 2004, 2005, that was going to play such a huge part in what we do, is we are capturing so much content for now social media, for our websites, to generate more leads through our practices. So photography became a huge component of what we do and what I do in practice every day. Yeah, but to answer your question, as far as like lead gens, that kind of thing, you really have to build a brand that you're passionate about, or else you're going to be looking for what your return on your investment is constantly. You're going to look for like the sending in a direct mailer and expecting, how many patients am I going to get from my direct mailer? building a brand, is not like that. It's something that you have to be passionate about, you enjoy doing. It's just part of the job. I'm not really looking for my returns in the immediate right now. I'm looking for my returns in the future as I'm building something I'm just passionate about.
Most dentists will open a practice and they'll do everything. They'll do the root canals, they'll do the the crowns, they'll do the cosmetics, they'll place the implants, they'll extract the wisdom teeth. And I think one of the really important things here that I want to stress is, what you've done and what David has done, Dr. Hornbrook, is just take a huge dive into a service and just be a badass in that service. I mean, if it's fair to say, let me just ask you, because I don't know, do you do root canals and extract wisdom teeth and have, are you doing that kind of work as well? Cleanings and whatever else all the general dentists do all day long?
So my new patients all come for consults for porcelain veneers. So there's nobody coming to my office that wants like an exam to be like a general patient. So if I'm doing anything outside of doing a porcelain veneer, it's included in a case that I'm doing, but it's not going to include extractions and root canals. I can tell you that.
Well, and so that's the point. So this concept of branding is pick a service, pick a lane. If it's all on X, pick that lane. If it's smile makeovers and cosmetic dentistry, that's your lane. If it's root canals, that's your lane. And you can brand for that and you could be damn good at it. It's fair to say, you're a lot better than you were 3 years ago at doing this stuff. But if you were doing everything, you'd just be average at doing everything. And I think that's number one. I think doctors have the fear of not wanting to do what you have accomplished. And that fear component is, I got to go learn photography and I got to document all my cases and I can only do cosmetic dentistry and and so I think that's important. And to be honest, I failed at that multiple times. I'm a cosmetic dentist. And then when I have a couple of slow months, all right, well, I'm going to do other stuff. And then you just fall back into doing the other stuff instead of pushing through. So I think that's really important to stress. Let's Tori, let's do this. Why don't you play asset number 2?
I'm enjoying these assets.
You're not breakdancing on this one.
This is the Smile Stylist Training Center designed to bring you the latest and greatest in education for porcelain veneer treatments. We're known for our no preparation porcelain veneers. This next course I'm going to talk to you about is our Smile Icon course. What about the rest of your patients in your practice who aren't good candidates for no preparation porcelain veneers? Tony got veneers not just a few years ago, but she wasn't happy with her veneers. That's the kind of thing we learn at the Smile Icon course, how to prepare properly for the materials that we use to exceed the expectations of our patients. If you're new to doing porcelain veneers, haven't done that many cases, just getting started in doing porcelain veneer treatments, this is your start course, Smile Icon. This is where you get started to learn how to deliver better, more beautiful porcelain veneer treatments for your patients.
I have a special place for people like you that are educators, because it's a tough business. And for you to have that commitment, that drive, that alone in itself is, you have to be a little bit of an animal in a sense to want to just take on that. But tell me about Smile Icon. I know a lot of people that are watching and listening in, it's like, all right, well, I'm young, I want to get into it. What does Smile Icon, what is it going to teach the doctor?
Yeah, the Smile Stylist Training Center that you saw there, it's something that had been in my vision for a long time, to have my own training center. Because I've been in education for, like I said, with the Hornbrook group, right? So we're going back to like 2005 when I started there. And then I was with Clinical Mastery. I was the aesthetic director there, then the program director of Clinical Mastery series for like 10 years or so. And then finally, my vision was always to do something on my own. So, I had a little break up there with Clinical Mastery, where obviously we're still good friends. We have great relationships, but they knew I wanted to do my own thing. So I built the training center, which is, it's an offshoot of my practice. So it's connected to the practice. It is a state-of-the-art 18 seats, workbench style. So we got hands-on cementation workshops, preparation workshops. It's live patient. I work under a microscope so people can see what I'm doing. I have a 13-foot video wall that shows simultaneously what I'm doing while I'm working on a patient and what's going on in the room. And that's really immersive. And it's all reference-based type of literature or lecturing too as well. It's just, it's not just like I thought one day, hey, let me start lecturing. It's no, I've been like lecturing in hotel rooms forever, and finally I have my own place. So I'm like, just I'm so comfortable here. It's like, this is like my desk. I'm sitting at right now is my desk while I'm lecturing. So I'm just like super happy to have this place now. But the Smile Icon course is an anterior aesthetics course. So it basically teaches doctors who haven't had a lot of experience doing porcelain veneers yet, how to do treatment planning, case selection, occlusion, photography, how to do the provisionals, cementation, customizing provisionals, how to run through the occlusion so that the porcelain veneers don't fracture or break, how to communicate, how to do the sales, the marketing stuff. It's pretty immersive course for 2 days. Like you said, a lot of energy.
Yeah.
It takes a lot of energy. Yeah.
Yeah.
So that's basically the Smile Icon course. So most of the time in the Smile Icon course, we'll have newer doctors or doctors who have been doing porcelain veneers, but maybe not super confident doing porcelain veneers yet. And then you have the no prep course, which is more for doctors who have been doing porcelain veneers for quite a while. So I've got, AACD fellows in there, accredited members of the AACD, COIS graduates, those kinds of people go to the no prep course.
And that's the second course of your 3-course curriculum, correct? That's
the second course. That's not a prerequisite. The Smile Icon course is not a prerequisite for the no prep because these are doctors who typically have a little more experience already who are going to be taking the no prep course. The no prep course is a prerequisite for the advanced no prep course because it builds on itself. Because in the advanced no prep course, we're going to be doing full mouth rehabilitations by doing additive dentistry. So we're creating restorative space by opening the vertical dimension and centric relation and doing additive dentistry that way, doing no preparations. So it's a build.
So it's really wished that because I do believe that no prep is, if I can compare it to like an FP1 for all on X, it's a little bit more, I don't know, we always say technique sensitive to make it more special, but it does have a different eye to it, I would have to say. And then you also have to have, I mean, I get it, patients don't want their teeth cut and they don't want to get numb. They don't want shots. I understand that part. But to your point, it's like you have to be really selective in, because we get the patients in temporaries and they're like, oh, my teeth are so much bigger and they're not used to that, and that's that component of it, that word right there, when a patient says that, it's like, it kind of sets off some, alarms on.
It's funny.
Maybe
it's
I
funny that you
shouldn't
say
deliver
that,
the cake.
Shaheen. No, it's fun. It's funny that you say that because
Are my teeth too big?
I've had that situation too. Yeah, I was going to mention that your teeth look a little big.
Right?
And,
no,
I was going to say that too because one of the biggest critiques of a no preparation porcelain veneer is that it makes the teeth look bigger.
Yeah.
And by the way, any no preparation anything makes the teeth look bigger. I mean, even if you look at Marshall Hansen's technique, he makes the incisal edges 1.5 millimeters thicker. So any technique, whether it be composite, porcelain, or 3D printed, is going to make the teeth bigger. The difference is that, like, as you and I are talking about, like you did a set of veneers and the patient was worried that the temporaries made the teeth look too big, is that I think the real issue is that if you look at dentists before and afters, yes, I think they're using porcelain veneers as a treatment modality and they're making the patient's teeth look bigger. And the difference is that they're prepping the teeth. And so if you're going to make the teeth look bigger, why are you prepping them? I mean, we can do that fine without prepping the teeth. And so you've done this aggressive preparation to the tooth and you're finishing with a porcelain veneer that's just making the teeth look bigger. And I think that's the issue really in dentistry right now. Why no preparation porcelain veneers works is because it's proper case selection. So if we decide who the correct patients are and we know, then when we do the case, you can't tell we made the teeth look bigger. It just looks right. But no matter what no preparation, any material is going to make the teeth look bigger.
So you use the word aggressive, and it reminded me of this discussion I had on social channels. There are a lot of dentists, general dentists, that believe there's no reason to cut virgin teeth for cosmetic purposes. If you take a drill, if you take a drill to a tooth, it's over aggressive. Even if you're just doing a, don't break contacts, just a facial veneer prep. And the argument is always we damage the teeth.
Mhm.
So, and obviously you've heard of all this before.
Oh, sure.
Are you damaging the teeth if you are doing no prep? Are you damaging the teeth?
You're altering the enamel surface for sure. I think Dennis Wells' article in 2012, he wrote it as somewhat of a reversible technique that you could take off the veneer using, whether it be fine needle diamonds or erbium YAG lasers, you could remove the veneer. But to that point, I hadn't seen that done, but I did have a case where specifically I had two twins, identical twins, come into the office. Their names are Sam and Steph. And they looked so much alike, they were even hard for me to tell apart. But even though they looked alike, their personalities were like completely different. Like Steph was totally into getting the porcelain veneers. And by the way, their teeth looked so identical as well. Steph was all into getting the porcelain veneers, and Sammy was a little bit more reserved. And keep in mind, like they bought homes at the same time, right next door to each other. They bought dogs at the same time, same kind of dog. They had babies at the exact same time. So they're doing everything together. They're called the Tox twins. And they wanted to get veneers at the same time. So I did their cases completely no preparation. And Steph was super excited, but for some reason, keep in mind, these are all handmade. And for Sammy's teeth, they were made just, I'm going to say like a half a shade brighter than Steph's. And she noticed. And it would have made a difference if only we were doing one set of veneers, because they wouldn't have known if it was like a half a shade different. But when you compare them next to each other, Steph was like, yeah, I just don't, I can't get used to the fact they're a little brighter than Steph's. I was like, oh man, take 3 months, see what you can do. Maybe you'll get used to it and it'll tone down and it'll look good. But she came back 3 months later. She's like, no, I do want them darker. Now, I'm going to lie. I would lie to you if I said I've never done a smile twice, because that is 100% not true. I've definitely redone smiles in my career, because it is all about making patients happy through in the long run. I mean, that is what it's all about. So I redid her smile. And because there was no preparation, I was able to take off each one of the veneers. It took about 10 minutes per tooth. I used a fine needle diamond. And when she was done, it looked pretty much identical to the way her tooth looked before. Of course, the surface texture was a little bit different, but when she looks in the mirror, like, she can't tell the difference. And keep in mind, this was 3 months after we had seeded the no preparation porcelain veneers.
Yeah.
If you look at like Webster's dictionary of like what reversible is, it means reversing back to an unaltered state. But that's not true then. In that case, it's not reversible. But can she live a normal, healthy life and be happy without those veneers? In this case, yes, she could. So, and if it was 20 years later, she took the no preparation veneers off, you can imagine she really wouldn't remember what her teeth looked like. So there's some aspects of reversibility, like you can take them off, but you've altered the enamel. A dentist will be able to tell underneath the microscope. Will a patient be able to tell? Probably not.
It takes a lot of patience to be a branded cosmetic dentist, because you said it, man. Like, you'll look at a case and go, wow, that's like my most amazing work. And the patient will go, I don't like it.
Right.
And you're like, what the heck? How am I going to like, that's my best work. But then you have to redo the case. That's got to be like mentally, that's got to be so, I don't know what's the word here. So challenging.
But it's your job though. It's what you do, right? So, it's just part of the job. But fortunately, I mean, that really doesn't happen very often. If it happened all the time, there's a problem, right? I mean, you're not going to enjoy your job if it happens all the time. I mean, it's a rarity. Most of the time you catch things in provisionals if somebody's not going to be happy. Yeah. So you work it out through the provisionals. Obviously, you have prototype temporaries, and you make sure somebody's happy through that aspect. So, you want to make sure that's done. And then, but yes, there's a lot of me speaking to a patient now is different than me speaking to a patient 20 years ago, right? I mean, through the experience, and and they're coming to me and they're expecting my opinion or respecting my opinion, because they've come to me to get this done. But we have different conversations, like, for example, patients will have a little bit, maybe sometimes too much input in what they want their smile to look like, but it's not their specialty. They're thinking about smiles for 1 or 2 weeks. I've been thinking about smiles for, more than half my life, so I just have more information about smiles and how things should look. And I tell them, I'm like, listen, I know where we're going, and we're talking about a ship here, and I'm a great captain, and I'm able to get us to where we're supposed to be going. I've done this dozens and dozens of times. I know where we're going. I can get us there safely. But if you feel like you want to take the steering wheel and you want to captain the ship, then that's up to you. But I hope you know where you're going, because once you take over the steering wheel, then it's your ship. So I think just through conversations, I think it's more that we tend to be able to guide the smile a little bit more and kind of take over, just so the patients don't feel like, you don't want the patients to have so much control over the smile because that stresses them out. Patients that have so much control over the smile, they want to make sure they tell you every single little thing so it doesn't get messed up. And we don't want to set up that kind of communication. We want to set the communication where we're the captain and we're going to get you where you want to go.
Yeah, no, I mean, I get it. You're saying so many things, and after 25 years of doing this, I get the little intricacies of what could happen if your communication is a little bit off.
Yeah.
And how you guide the patient, being a captain in the of the ship, like you said. And it just could be something really small, and then it becomes a much bigger problem. Tell me a little bit about protocol. Is there a difference between, communication's gone, now we're getting clinical. Is there a protocol difference between cutting a tooth or cutting a smile makeover versus a no prep? What's the protocol difference?
So I have a classification system for no preparation. So there's three classifications. There's the no preparation classification 1, which is just purely prepless. You take an impression, you deliver a set of veneers. And then I have the NPCL2, the classification 2, which I call Smile Equilibration. Sometimes it's going to help the shaping of the tooth in one reason or another. Sometimes you want to shorten a tooth a little bit. You want to contour something back 0.2 millimeters, something I call an internal mini wing. Like sometimes it'll help to touch a tooth in one place or another. There's no anesthetic. It's 0.2 millimeters. The patient can't tell you did anything, but 0.2 millimeters is like a football field in a prepless veneer. I mean, we're doing feltspathic porcelain veneers that sometimes are only 0.2 millimeters thick. So that's giving you the room for the entire veneer in 0.2 millimeters, but the patient can't see you did anything. They look in the mirror, everything looks great. You need to get them numb, but it assists the case so much. Sometimes I want to do it. Then I have a third classification where it may be restorative management. Maybe you need to replace composites, or you're handling some cavities, or up to 0.3 millimeters of shaping of a tooth. And that's really your transition into minimal prep up to the point of putting a finish line on the tooth. Once you start prepping margins on a tooth, then to me, it starts to be minimal prep. The issue right now is there's really no good classification for minimal prep. And there was no classification for no prep. So people say no prep. What do you mean by no prep? So a doctor like Dr. Oscar Gonzalez, I heard speak. He's a Spanish doctor who does some no prep, and he calls it minimal prep when he barely touches the incisal ledge. But his minimal prep is so different than what other doctors are calling minimal prep, where they're putting chamfers on the teeth and they're in mostly enamel, or more than 50% enamel. So there needs to be a little stronger classification. Brian Lesage came out with a classification system in 2013, something like that, where he went over through minimal prep and how much dentin or how much enamel's left. That's helpful, but we need some kind of guideline, because right now it's kind of a little bit all over the place, if you know what I mean. So
your 3 classifications basically don't allow a margin to be
that's right.
prepped, but you can kind of reshape the tooth in that no prep zone. And then as soon as a margin's created, that converts into
and
a
you start to get into minimal prep. Right. A little bit of I call it smile equilibration, because we equilibrate the teeth all the time for occlusion. We're not prepping the teeth. A lot of times when you're done doing a smile equilibration, the smile looks better. Like if somebody finishes ortho and you want to level the incisal edges a little bit, or plane a distal facial back a little bit, you're not prepping it. I mean, you're making it look better. So, yeah.
So let's talk about CR, canine guidance, and patients that have some wear on their lowers, right? Are those, when we used to do our smile makeovers at LVI, if you really look at the occlusion, nobody really had proper occlusion, and we still did the 8 or 10 units. I mean, if you want to really dive in, it's like everybody needs a full mouth almost, right? With proper bite and all this kind of stuff. So what is the occlusion?
Different philosophies.
If you got some lower wear, so if you got some lower wear and you're concerned about how teeth come together and all that kind of stuff, what is your no prep protocol there? Are they still a candidate?
So visually, I like to break down my patients into like a risk management assessment for cosmetic dentistry. And so we look at tooth wear, anterior tooth wear, posterior tooth wear, and make a determination, because a lot of our no preparation cases are feltspathic, and people are concerned about using feltspathic. They don't typically use it in practice. Most of the time they're placing lithium disilicate, or because it's stronger. And so when they think feltspathic, they're thinking they're placing a weaker material, has a lower flexural strength. And so, they're afraid that it's going to break in the mouth. But when you're doing no preparation porcelain veneers, you're bonding to 100% enamel, and the tooth maintains its complete strength. Like you haven't removed any of the enamel, because when you remove the enamel of a tooth, when you're doing a preparation, the force under that tooth during load is transferred to that veneer more because of the flexure of the tooth when you remove the outer enamel. If the enamel is 100% intact, you don't remove it, the tooth's still very strong. So it's like putting like a piece of marble. When you put it down on the floor, you can jump up and down on it, obviously, but a piece of marble in the grass, if you jump up and down on it, it's going to break. So that's the same thing with feltspathic. It's very strong when it's bonded to an intact tooth. It's just when you start to aggressively prepare tooth and then you want to use feltspathic, now the flexure of the tooth is being transferred to the material, which is going to be the feltspathic, meaning it's going to be under a higher stress during function. But yes, we do an assessment of the patients prior to. In a nutshell, if somebody has incisal edge wear on the lower or chipping of the anterior teeth, I'm looking at their posterior teeth. If they have healthy posterior teeth, then I'm looking at them as a patient who I'm probably going to be equilibrating before I do the veneers. If I can equilibrate the patient, create a proper bite for them, where I have bilateral, simultaneous, equal intensity contact, then I'm comfortable still moving forward with the veneers. If the patient has posterior tooth wear and anterior tooth wear, that's when I draw the line, and I know that I'm probably going to be doing more than just a single arch of feltspathic porcelain veneers. If they have worn down posterior teeth, and I want to give them beautiful anterior teeth, the mouth is a system where the front teeth and back teeth, as we know, work together, so we can't ignore the back teeth. It's more than just an equilibration. These are cases that are more of like our advanced no prep cases, where we're opening the vertical dimension of occlusion and restoring them in CR, creating restorative space. So yeah, it was just managing the occlusion in centric relation is how I handle patients who are wearing down lower edges or chipping anterior teeth. Yeah.
Well, you said a lot there, man. I'm trying to catch up
Sorry.
to you. Hold on. I got 2 more lines to go. Hold on. No, look, man. There's so many questions. So let me start with this question. Now, would you, if you're cutting and you're in dentin, would you use feltspathic or would you change your material?
I would still use feltspathic. Depends on how much dentin is exposed. Depends on how much dentin. So historically, when we look at how much enamel we want, if you look at certain studies, 100% is the best, 80% is the second best, and then there's not much difference between 80% and 50% when it comes to doing your veneer. Okay, doing for retention purposes, and what I'm looking for is 80%. That'd be fantastic. If it's getting to be 50 to 80%, and the load is going to be more transferred to the material, I may be now switching towards doing something that's in a lithium disilicate, because my prep design now has really changed for the case. And that's just for me, in my experience, how I would handle it. So other people, I'm sure, have other experiences who have been using feltspathic.
Yeah, that's such a good point, because that's what I was going to go into next is, would you change into E.max if you're more into dentin? And it sounds like anything below 50%ish, give or take, on dentin, you'd convert.
You can not just convert into E.max, but we're losing retention through adhesion when you lose more than 50% of enamel. So we're looking at more circumferential retention, where we're not doing just what we call a minimal preparation veneer. Now we have to wrap around the palatal surfaces of the tooth. We do like a save the cingulum prep and get at least 4 millimeters of cohesive retention around the palatal surface and proximal surfaces of the teeth as well. So we're kind of losing the adhesive properties of what a veneer is supposed to be.
That's interesting. So then you would convert that into a full crown,
save the
is what I'm
cingulum.
hearing, correct?
Yeah, if you don't have enough enamel, then you really need to find more cohesive retention. That gets to be more aggressive. I mean, that's the issue. That's the issue with porcelain veneers. It's always been the issue with porcelain veneers. It's the patient says, I want porcelain veneers. You say, that's great. It's a more conservative treatment. Then the patient comes into the practice and you have the best intentions when they're lying back, and you start prepping the teeth for veneers. And then before you know it, you start getting, the teeth start looking more tapered, and you're like, wow, these don't really look like I thought veneers were supposed to look like. They're starting to look a little bit more like crowns. And then before you know it, you're like hoping the patient doesn't look in the mirror, right? You put things over the teeth. You say, don't look in the mirror because you can't unsee it. I mean, at what point, do we say, okay, is this my protocol for a veneer? I mean, am I prepping this right? If all my cases are turning into cases that the patient can't look into the mirror anymore, that maybe that has a different name than a veneer, right? And so, like, there are protocols that we can use to save teeth while we're prepping them for porcelain veneers, that they still keeps them minimally invasive and saves the enamel. And that's what we're really talking about doing.
Yeah, I mean, I need to take a no prep course, dude.
Be my
You know what I'm
guest.
saying? Like I'm being look, like I'm telling this. I've been accused of being over aggressive with my prep design. I show my preps. I'm not shy, you know,
Yeah.
because a lot of people show their before and after. They never show their prep, right?
Right. They say
And
minimal prep or no prep, but they don't show the preps.
I show the prep, and people beat me up. I'm like, all right, I'll keep showing my prep. No, I'm kidding.
No prep has a no prep's been called a marketing ploy before. It's a marketing ploy. Like you're just telling your patients that you're doing no prep just to get them into the office, right? It's just attracting more patients who aren't interested in doing porcelain. Kind of like, I think if you call it a marketing ploy, also a marketing ploy is called a free cosmetic consult. Yeah, in hopes that they'll get their cosmetic dentistry done with you. Yeah, a marketing ploy. It attracts patients to your practice who otherwise wouldn't have been interested in getting porcelain veneers because they thought they needed their teeth shaved down. So
yeah, you know, yeah, it's this. I just had this discussion with Paul Vigario with Serve CT about branding versus marketing.
Those guys know marketing,
and it was a great discussion. We can maybe talk a little bit more about that. But I want to go back to this enamel dentin cementum. How does feltspathic bond to cementum, and what is your protocol there?
The bond for feltspathic to enamel or to dentin is the same as it would be for a lithium disilicate or other glass ceramics. So
Okay.
where the protocol changes is that feltspathic, before it's bonded to the tooth, is extremely fragile because it's made so thin. If you put a little too much pressure on it here or there, it will fracture, as opposed to like a lithium disilicate where you can drop it on the floor and it'll be okay. You know, it's like, you know, the days I deliver a lithium disilicate case, it's just like, I'm just like throwing them in because the feltspathic cases they're so much more fragile. So I changed my cementation technique so I don't have issues bonding in the feltspathic veneers. Because what I was doing is I was using the same cementation technique for the feltspathic veneers as I was the lithium disilicate veneers. Then I had a couple crack during cementation. I realized I had to change my protocol.
Well,
and when I changed the protocol, I realized the way I changed it made it even easier to clean up the excess cement for light curable adhesive.
Tell me what you changed. I mean, obviously, I'm going to ask you that question, dude.
Dude, so I'm like, I am actually a pretty modest person, and I don't like personally, like I can't stand arrogance. I like, that's kind of my thing. Like I won't get along very well with somebody who I think is arrogant because I don't know, like in my personal opinion, like there's nothing that I'm doing is like good enough right now. Like everything has got to be better. And so I'm never at a point where I'm like, yeah, I'm good at that, because I look at it and be like, that's not good enough. So so arrogance bothers me. But I will tell you one thing though, when it comes to arrogance, I am the absolute best in the world at something called the tack and wave for cleaning cement, for cleaning light curable cement when you're doing porcelain veneers. Do you know what the tack and wave is?
Yeah.
Yeah, you do you tack dead center of each tooth, you do a wave technique, and you peel off the cement. And I could literally peel off the cement in one piece the vast majority of the times. I mean, it was just this clean pickup of the cement. I'd take a picture of it for my Instagram. I'd be like, check me out. I'm the best tacker and waver in the world. It's a small thing to be the best at, but I'm definitely the best at that. Dude, but I changed the protocol.
Dude, you're so arrogant.
You wish. You wish.
I wish I was arrogant like you, you know. I attack and wave. I'm definitely not the, I don't even know if I'm in the, dude, I'm not even top 10 in the world for that. You know what I'm saying?
Not even top 10? You
probably not even the top 100.
You don't need the stress. You don't need the stress. All right. So I changed it to now I clean the cement before I cure it. And I have a protocol for, I still tack it, but then I clean it and I use a flossing technique. So I'm flossing it before any cement is cured proximally, because the issue is when you're doing a tack and wave in feltspathic veneers, if you're trying to pick off cement that's not quite cured yet, and it puts any force on that veneer that's not bonded to the tooth yet, because the cement's still kind of wet underneath, it'll fracture the veneer because it's so fragile. So you want
say that one more time, Jason. Sorry.
Okay.
Say that one more time. Say that one more time.
All right. So when you're bonding on feltspathic veneers, they're very thin, right? They're very fragile. So if you use the tack and wave technique with thin feltspathic veneers, you have to be very careful when you're picking off the cement, because a wave cure is partially cured cement. So the cement underneath the veneer is partially cured. So if you're picking off a piece of cement that's a little overset in, let's say, the proximal area, and you're pulling it off, it could bend the feltspathic
Yeah,
veneer.
yeah,
And as
yeah,
it
yeah.
does that, it fractures because the cement under the veneer is not cured yet. You don't want to put any force cleaning the veneer until it's completely cured. So I use more of a wet technique when I'm cleaning the veneers. I don't do a wave. I tack, I floss, I use my brush more. I do a very fast wave. I do one more floss, and then I finish cleaning the wet cement, and then I do a final cure. That way I don't have any issues going proximally after I've already cured the veneers. And so there's no cement left, and it's a super fast cleanup. Of course, there's some nuances of that. I can't go through like every single step.
No,
Not
that's
every kit,
fine.
but that's
No,
the
I
nuance
I
of it.
got you. I got you.
Yeah.
Look, I tell you something that would freak me out when I start delivering these cases is making sure that I'm putting him in properly and staying in properly, because when you cut contact in a 3/4 crown, I mean, it pops right in, it gets stuck
Yeah.
in there. Where with no prep, I mean, like little line angle off, and you got those top clients, it's like
Yeah.
it gets kind of hairy, right?
Yeah. Yeah. Absolutely. Absolutely.
Um,
Yeah.
that would be the part
It's
that would,
technique sensitive. Yeah.
yeah,
I
use
mean,
that word, man.
we're always seeding the 2 front teeth first, I mean, it's like cure cement. So you got to take your time. People still want to rush when they're using like cure cement, but you got to know you got all day with like cure cement. So we're putting in those
Yeah.
2 front teeth first, making sure the incisal ledges line up, checking it from the occlusal, stand up, get in front of the patient, check that, because that's the starting point. Make sure those 2 front teeth are in right. I mean, you can almost
So-
always tell when cases don't go in right by looking at people's before and afters, because the technicians always make those incisal embrasure spaces symmetrical.
Yeah.
So if they're off,
When we first started doing these cases, it was Impress, and we were getting some cracks on Impress,
Empress.
similar to Impress. Sorry, yeah,
Empress, yeah.
And we're getting some cracks, maybe behaved a little bit like feltspathic, and then
It's a loose side reinforced feltspathic. It is feltspathic,
yeah,
but it's a pressable feltspathic.
right. So then E.max came out, and there were no cracks. So the technique sensitive,
Stronger, so okay.
That's right. So I was throwing it against the wall. All right, we're gonna be good.
Yeah.
No.
Yeah.
But
So why?
But
so why are we using feltspathic, right? I mean,
I wasn't. I don't.
Why use this? Why use the stress, right? Why add the stress of using a feltspathic material when you could place E.max, more predictably then, because it's less likely to fracture, during seating. Maybe you feel like it's going to be stronger under occlusal load.
Yeah.
And feltspathic has some properties to it that you have trouble getting from a lithium disilicate. It is the ability to make a shade change in much thinner increments. Whereas you use like a lithium disilicate, you're looking at making a shade change, like one shade change every 0.2 millimeters. With a feltspathic, you're making one shade change every 0.03 millimeters. So in very thin increments, we can take a darker tooth and make it brighter, like a tetracycline case. If you want to make a tetracycline case look brighter, you're going to use feltspathic, because if you have to prep a tetracycline case, it's going to get darker, and then you're going to be defeating the purpose. But if you can do a minimal or no preparation on a tetracycline case, use feltspathic, and then you can brighten up that tooth in a much thinner increment without it looking bigger. So that's one of the reasons why I use feltspathic. The other reason why is because it just looks more natural. The colors of white look more natural than the lithium disilicates do. And for the most part, that's generality speaking in lithium disilicates, though. Amber by Hosbio is a lithium disilicate that has smaller crystal sizes and does look a little bit more like feltspathic. So you have options out there.
Sometimes I ask myself, why am I doing the live show? Like, what the F am I doing? This mad, like, what am I doing? And then now I understand why I'm doing this shit, because I'm learning as you're talking.
You're punishing yourself.
Dude, I'm learning from you, and I'm like,
you're a worker.
I'm trying to be, I know what I'm talking, but no, dude, you're giving me like that whole tetracycline with feltspathic. Like, what?
Bro, ask me something about implants.
Who cares about implants, man?
I don't know, man. I know.
All your patients brush and floss.
Institute. I went to the Mish Implant Institute, and I got home and I placed probably like 16, 20 implants. I'm like, this is just a wreck in my day. I got to set up the implant stuff. I got to do the sterile stuff. I'm like, this is just not me. So it's one of those cases where it's like, implants is now the future. You got to learn how to place implants, because it was a financial gain thing. It's like, if I place implants, it's going to be profitable for my practice. But that doesn't matter, because you're not going to enjoy. If you don't enjoy doing it, then it's not going to matter. Right.
Oh man, I
get
into discussions on social about, I don't place implants, and I give those all on X guys a bunch of shit all the time.
Yeah.
Right.
Okay.
And so
Yeah.
they're like, listen, you don't even place implants. I'm like, yeah, but do you know how many people are suffering because they place implants and they don't know what they're doing because they're
Yeah.
taught incorrectly?
Yeah.
Anyways, that's a different discussion, but
Yeah.
I
And
want
one
to
that
go
goes over my
back.
head.
Yeah, no, I mean, I stopped placing implants 2012 and I placed, I don't know, 70, 80 of them.
I wish I could stop restoring implants.
Well, we've had that discussion too. But seriously, like, I appreciate how open you are, and I saw your story that said "tell all," and I appreciate you sharing this because whether you're experienced or not experienced, I'll tell you my story just real quick.
Okay.
I've never delivered a feltspathic veneer. I've delivered Empress. Did I say it right?
Empress. Yeah, Empress.
Empress.
Yeah. You know,
Empress.
E.max stands for Empress to the max.
Okay. Did you just make that up?
No.
You making shit up, dude?
Doesn't matter.
But so I've never delivered feltspathic, and I want to. I want to, and I want to get into that no prep game. And I'm intrigued by this whole discussion.
Dude, let me tell you, like, the first time, like, you look
the
at,
reality is,
so when you look at like the perfect no prep case, you're like, and I'll show you tons of those, and you deliver like this beautiful case, you didn't touch the teeth. Then the next thing that comes into your mind is you say, how come I prepped that last patient so much? Because all I really need to do is make that patient's teeth look like the perfect no prep case, right?
Dude.
And what's it going to take to do that?
You know what I'm going to do when I deliver my first no prep case? I'm going to say the last 25 years of cutting cosmetic case. You follow me?
Yeah.
Forget that last patient. But I think there's a lot to be said about minimal prep, no prep. I don't know if it's necessarily a craze about that. I think there should be a lot more discussion about that on social platforms. It's not as sexy because, all on X, you make 25 grand in 30 minutes. And you're doing so much more work yourself, in a sense, with, your camera, branding, your center. There's just a lot going on. How many days a week are you working? I mean, do you have a life outside of your training center? Talk to me about that.
So I work 3 days a week. I work Monday, Tuesday, and Wednesday.
Oh, dude, you're so arrogant, man. You're so arrogant.
Dude, the thing is like I get doctors in the training center who are working, 5 days a week. I'm like,
yeah.
I'm like, that's tough, man. It's tough to focus on those cosmetic cases when you're running around doing so much general dentistry. And I don't think you realize it's like when you focus in on those profitable things that you really love to do, like you can make more money in 3 days than you can in 5. I mean, you know that. And so I think it's just getting over the hurdle of like, it's like, you just got to do it, and just not, once you make the choice, they say, once you make a choice, you're cutting off any other options. Right. And that's the same thing. It should be like that. Like when I wanted to do cosmetic dentistry, I said, if I'm going to do this, I want to be considered one of the best in the world. Now, what do I have to do to make that happen? And so it's like jumping into a go-kart. Like I don't do it enough, but I like racing go-karts at like these Audubon places. Once you get behind the wheel of a go-kart and you're steering this thing, you should be looking to see like where you want to go. You should be looking at like the hairpin turn and the barriers that you might hit, or the cart in front of you that you might hit trying to get around them. You're steering to where you want to go. And by the time, if you accidentally bump into something, like you're figuring out how to still get around the corner and make up that speed. You're not sweating that you bumped into a barrier. Like you wouldn't do well, right? And so that's the same way, I've gone about practice. It's like I hit barriers all the time, but I don't focus on those small failures because my vision is only for that one thing. And so, and so that's in part. And for me, having you can't be one of the top cosmetic dentists in the world unless you make money doing what you do, unless you have the experience and you can talk the talk. Because I can teach you protocols all day that I wrote about in my textbook, but I've never done it in real practice. How viable is that? How are you going to take that back Monday? You could take some pieces, but you can't apply it to your practice. I'm telling you what I've been doing for the last 20 years in my practice, 3 days a week, that does $2 million a year. And so that's the kind of training that we get at the training center. It's hands-on, but also I've been an educator for this long, but also I'm showing you how I do it in practice, but it's literature-based. So I'm making sure we pull references on what I'm doing. So you really get a good, solid education here.
I want to go back to the protocol, man. Tell me, do you spot etch your no prep temps?
Oh yeah.
Okay.
Yes,
So
I spot. Yeah, I mean, I spot etch on my temps. Spot etch and bond. I spot etch and bond on my temps.
Okay.
Yeah, you know, just if you're spot etched dead center of each tooth,
yeah,
it's easier to get them off. Yeah, it really keeps them from coming off. It really does. And then when you go to take them off, you know exactly where you spot etched. And so as you're taking off the veneers, you know, you can just remove where you spot etched and bonded, and the veneers come off a lot easier too.
Yeah, no, I get it. I'm just thinking about the aggressive camp. You know, they're going to say, well, that damages the tooth too. I was like, shut up. Right. Next thing, let's go back. Let's go back to occlusion. Talk to me through that discussion as far as occlusion. So anterior, you have where; posterior, you don't have where. You're good, or you're equilibrating.
That's an equilibration case.
Okay.
If you have anterior wear and posterior teeth are healthy, that's an equilibration case for me.
Okay. And then if anterior wear, posterior wear, now that's a rehab case.
That's correct. Yeah.
Okay.
Then we need to restore the occlusal surfaces of the posterior teeth to be able to get ideal occlusion, or else there's really nothing to equilibrate. So we need to restore the posterior teeth. Now that's where additive dentistry comes into play. This kills me. Okay, so you get a patient coming to your practice who's been coming to your practice for a while. They're wearing down their posterior teeth, as a lot of patients are. They have large restorations or maybe existing crowns already. They come to your practice, you see a large amalgam, they're wearing down the tooth, and you tell the patient, we need to do this tooth. Inevitably, it's one tooth at a time. You say, this tooth is looking bad enough, it's time to do a crown. Meanwhile, there's 4, 5, 6 other crowns on 4, 5, 6 other teeth that are wearing down with large fillings, but you only present one tooth at a time, either because that's the way you learned, you don't feel comfortable with occlusion, or you think that's what the patient will accept because you don't think they can afford to do a lot of dentistry. So you do that one tooth at a time. But restoring that tooth who's already worn down, you gotta prep it for the crown, you gotta reduce the occlusal surface, and then you build it back up into a flattened state to work with an occlusion that's already not working for the patient. In my practice, that would be at no way, never. I would never treatment plan one tooth at a time. I would prefer to put off doing any of the restorative work on this patient to talk to them about what we can do in terms of building up the bite, opening the vertical dimension of occlusion, making it additive dentistry, and fixing the smile. Because at the end of the day, if you fix one tooth at a time on this patient, they're going to still spend a lot of money over the next 15, 20 years to fix their mouth, but they're going to hate you. They're going to hate the dentist. They're going to hate their smile. If we can talk to them and say, hey, listen, if we do this all now, we can control the bite better. We can build things up. I don't have to file down your teeth. This is all additive dentistry now, so it preserves all the tooth that's underneath there. Yes, it's more money now, but you'd end up spending that money anyway over the next 15 or 20 years. But wouldn't you rather have teeth that are healthier and have a smile that you absolutely love? We'll figure out a way to pay for it, but let's get it done now, as opposed to dragging it out over the next 20 years, hating your smile and hating me.
Okay. So, dude, like, you're never going to go home tonight. Like, stop. So if they have a large restoration, and are you doing additive treatment? You're still going to remove the silver, are you not?
You're going to remove the silver and build it back up, do new filling in that tooth, and then you're doing additive dentistry.
Got it. So you're bringing them back into normal occlusion, and then you just do the vertical opening.
Open the vertical dimension of occlusion.
All at one time.
Yep. We do that. We do that typically with a COIS deprogrammer. If you've been through the COIS continuum, I'm a graduate of COIS. We use the COIS deprogrammer to open up the vertical dimension of occlusion. It's a deprogrammer that a patient will wear. It sets the bite to the proper spot because it allows the joint to go to centric relation. The patient can comfortably be in that position because it relaxes the elevator muscles, the depressor muscles, the pterygoid, that kind of thing. So the patient comes in deprogrammed, and we restore the patient in that deprogrammed position. So it makes it easier to take the bite.
Let me say something about that.
Okay.
So Las Vegas Institute was a neuromuscular camp.
Mm-hmm.
And COIS, again, this is kind of foggy for me right now, so I might, miss a few pointers here. But COIS didn't believe in neuromuscular, bring the jaw down and forward. And then he started, I believe, right around 2008, 9, 10. I could be wrong. he started to introduce the deprogrammer, which was bring the jaw down and forward. Is that what you do with your Kois deprogrammer?
No, the deprogrammer doesn't bring the jaw down and forward. It allows the muscles to relax and the joint to go into its centric relation position. So the condyle seated in the glenoid fossa, and that could be a more forward position, but it's usually up and back. So it's not usually a forward position because some people are constricted, and constricted people, the jaw is forced back. And if they wear a deprogrammer, the jaw would come forward, and that would be kind of what you're saying. But for the most part, it's using the most anatomically correct position for the joint, and it's allowing the muscles to find that position. And I think that's kind of like what a myo monitor, you hook somebody up to a TENS unit, the myo monitor.
Are you
No.
tensing the patient?
No, we're not tensing the patient. The deprogrammer
How do you relax the muscle?
The deprogrammer separates all the teeth with one point of contact between the anterior teeth and all the posterior teeth out of contact. It allows the muscles to stop doing their hypercontraction. When teeth contact before they're supposed to, it creates basically what an interference is, and it creates hypercontraction of muscles. So your masseters, your medial pterygoids are firing at the same time as the lateral pterygoids. It puts strain on the muscles, and then the teeth find what is a habitual closing pattern using proprioception. So the patient walks around every day using proprioception to get their teeth together. When you put a deprogrammer between their front teeth, it takes the teeth out of occlusion, allows the muscles to work in a coordinated fashion, which seats the joint into the glenoid fossa. And that's the position of pathway of closure for which you want to restore that patient.
So you're basically unfiring the masseter and the temporalis by that appliance, the deprogrammer appliance, correct?
It relaxes them. It takes out the hypercontraction or the incoordinated muscle activity, and relaxing them allows the joint to seat. It's kind of like usually when things are firing in an incoordinated way, something like, say, the lateral pterygoid, which is your opening muscles firing. So it's under tension. And so unless that lateral pterygoid relaxes, then the condyle is not going to be able to seat in the glenoid fossa because it's holding the joint forward.
Are you putting
and the disc?
Are you putting canine guidance on your final full mouth rehab?
Not always.
Okay.
Not always. If I think somebody's going to grind their teeth at night, and that's something I want to be able to control, like a Bruxer, I put canine guidance in. Most of the time, I'm just removing chewing interferences. And a lot of times the canine is a chewing interference. So what you're saying is like, do I lie the patient back and have them grind side to side to make sure there's immediate canine disclusion? That's not always my main goal.
Yeah.
My main goal is to make sure while patient's chewing, they don't hit their new restorative work. What you're talking about is protecting somebody's restorations when they're grinding.
Yeah. So in neuromuscular, we put them into group function on the posteriors. Canine guidance isn't there, but no, interesting. So this additive is just basically put them in the deprogrammer, find that position that's most ideal where they're most relaxed, and then just build them to that.
Build them to that. And that's the pathway of closure you build them to.
And then what material are you using for your restorations?
So in the anterior, I'm typically using feltspathic. If we're opening up the vertical dimension of occlusion, I'm usually doing that over the posterior arch on the mandibular arch, and I'm using a lithium disilicate from the premolars posterior.
And then you build it up to the height of contour, since you're not going all the way to the margin on those, right? Just height of contour as far as your...
You go all the way to the margin. Mm-hmm.
You go all the way down to the margin.
Yeah, because when you start building out the facials of, say, like the anterior teeth, and you don't do it to the posterior teeth, they fall back.
Yeah.
So you notice that they're darker and they're kind of pushed in a little bit. So
are you covering the lingual as well? No, just the facial.
No.
The facial.
Facial and occlusal. Facial and occlusal.
Occlusal.
Occlusal. Yeah. New surface there. The
that's right. No, that's cool. Hey, I said impress 5 times wrong, so it's all good.
Impress. Yeah,
very cool.
They stopped making Empress. They have Empress now for milled blocks, but they don't have it as a pressable ingot anymore. So a lot of technicians don't use it anymore.
Tori, play asset number 1 for me, please.
Are we gonna? Is this the breakdancing one?
That's right.
Okay.
All right, we're at a Smile Icon course right now. This is March, isn't it? 2026. This is a Smile Icon course. We have Cheryl right here behind me. She's the first patient of the Smile Icon course. She's getting temporary veneers today. She is kicking off this amazing weekend with a beautiful new smile. What do you think of this? You haven't even seen it yet. No. She hasn't even seen it. What do you guys think of the smile? It's awesome. It's awesome. Like, what a transformation. Now, we still have a lot of work to do. Not a lot, like a little bit of fun stuff to do to make the smile look good so you can leave on your cruise with this amazing smile. But what we're gonna do next is actually let her look in the mirror and see this transformation firsthand.
Oh my God. Oh yeah.
Cool, right?
Yeah. Look at that.
Yeah. How long has it been since you saw your teeth look that good?
Never.
Cool. So this is, remember, this is just an overlay. It's not even close to as good as it's gonna look when you leave. This is just a placeholder.
Yeah, my smile just
Came to life.
Who knew? Look at that. That's crazy.
Crazy. Cool. All right, now we just have to do it.
Jason, very cool, man. I love the colors, the marketing, the branding. I think it just looks amazing. Before we talk about your courses again and we finish, tell me a little bit about how you brand. What are you doing? Are you bringing a videographer into your office? Are they following you around? Tell me a little bit more about your branding and you know, that madness.
Yeah. So I realized in practice, obviously, that like is going to attract like. And so that's what I tend to put out in social media, what I want to bring more of into the office. So if you land on my Instagram, you'll see like 99% of what I'm putting on my Instagram is no prep. If you actually saw what I did in my practice, you'd see I prep a fair amount of patients, but I don't post them on my Instagram. The reason why is because like attracts like. So I want to draw in patients into my practice where they see that people like them are going. Those patients typically have fuller lips, smaller teeth. They want their teeth to be a little bit bigger. I mean, if a patient's connected with me because, oh, that's me too, I wanted my teeth to be a little bit bigger, that's a greater chance that that's a no preparation patient than one who's just found me through a Google search. And so I'm being more specific about who I'm attracting into the practice. Dude, my social media is pretty good right now, but like I was all in on my website. And I was a little bit later getting into Instagram just because my website performed so well. I mean, we were #1 for all relevant search engine terms like Cosmetic Dentistry Jacksonville, Porcelain Veneers Jacksonville, Smile Makeover Jacksonville. I mean, dude, our Google was off the chain. But then I had to update the website because it was just getting old. And during the process of the update, the website looked cool, but they forgot to do the redirect. So they didn't redirect our new website from our old website. And we lost all of our search engine ranking in like a week. It was gone and we couldn't get it back. And dude, I was so frustrated, but it's like, there's been a lot of times in my practice that have been like that, where it's just been, I've been super frustrated because that was obviously going to be a financial hit for me. And that's when I went all in Instagram. And really for Instagram, it's a creator's world for Instagram. You know, I already do the photography. I enjoy doing video. You know, I taught myself Photoshop. I taught myself to do Final Cut, you know, before, obviously all this stuff before AI. And so it's just a natural fit for me to take pictures and videos and then edit them into Final Cut and create my own content. But I found out that like, if I do this, I'm never in it. And that's a problem. So I want to be in it. And so, this was back in the day, like, do you remember when we used to do testimonials and like used to just put a camera in front of the patient's face and be like, so why did you choose me? And then they just let me talking to the camera. Dude, I broke that wall down. I'm like, forget this. Like I sit down next to my patient now. I'm like, we're going to talk to each other, because what makes more sense is like them not talking about their experience, but how they relate with you in their experience, not them just telling you some things like, oh, I love my new smile, but like how they love you and the process of getting their new smile is way more important for attracting new patients. But I found out I wasn't in it. So I hired somebody who's a patient's son who graduated from the Savannah College of Art and Design. I paid him not enough money. He walked around with an iPhone, did some editing in Adobe Premiere, and I was in the videos. But then he left because he was going to Los Angeles. He left me without a videographer for some time. That's when I started doing an Instagram search for videographers. And I found my newest videographer. His name's Chris. Chris works for me for maybe 4 years or so, shooting that high quality video content, the special effects and CG that he was doing before AI. So it's really time consuming stuff. Yeah. And just recently I brought him as a full-time creative director here to help us out with the training center and everything. But like now with AI, dude, it's like he integrates AI into his workflow, and I mean, that's a whole nother thing to learn, man. So yeah, so that's a piece of the branding and how we kind of got to where we are.
You're going to get 50 clips of this show, at least 40, maybe a little bit more. So talking about AI, it's coming.
Dude, yeah. So learn it.
Yeah, for sure. So What's next for you? I mean, I see you as so driven in so many, like the fact that, you know, you said that I'm just never happy is kind of like me, dude. Like it's a little bit, you know, my wife's like, just sit down, you know, just sit down and chill. And it's hard. It's hard.
Yeah.
What's next for you, man?
You know, right now with the training center, I'm developing the content to a higher end. You know, I mean, obviously the reviews that people are coming in, they really like it, but like, this is like my baby now. So I'm constantly working on content. I'm constantly reading references, pulling references for this, developing new course content, improving ways that doctors learn here, and filling seats. You know, it's funny. It's like, you know, you spend so much time getting patients into the practice, like you're filling seats in the practice. This is different. You know, this is actually putting dentists in seats, but it's kind of the same, you know? So it's just kind of a new baby. So I was telling my dad came to visit the other day, I was telling him how happy I was that I had the training center because I enjoy thinking about it. So that's what I spend my time thinking about. So just more with this and just kind of growing the training center. I think that's kind of on my plate right now. I think that's a fair amount. Doing stuff like this, promoting it.
Any breakdancing courses coming up for you, or what
Dude,
are you doing with that?
Man. I would love that. I play soccer too.
Hey, you know,
I'm a soccer player. I enjoy getting out there and playing.
Well, are you playing still?
We have to get out and kick the ball around.
Yeah.
Yeah.
Man.
About 2-3 years ago, I hurt a meniscus, and then I rested it, and then I played again. I hurt the other one. I said, okay, maybe I just stick with golf and tennis.
Yeah, those are real sports.
Real sports. It hurts when you can't play soccer anymore, right?
Yeah. Well, that's a discussion. But yeah, that's kind of my sport. Kind of my sport. Dr. Jason Olitsky. Listen, man, I appreciate your time. I know your wife's coming on in a month, 6 weeks or so. We're going to talk to her. I'm going to get the real truth about you from her.
That'll be good.
So
just to tee that up, you know, my wife's a dentist. She's retired, and she's retired. She stepped away. She started doing something else from home, replaced her dental income in, I would say, 8 months to a year. So that'll be interesting for sure.
I'm definitely going to ask her about what you guys did in the clinic in the back in those courses back in the day. So. Jason, thanks for doing this, man. I appreciate it.
My pleasure.
Yeah.
My pleasure. Yeah.
Thank you so much.
Enjoyed it. Thank you.
Dr. Jason Olitsky, Smile Stylist. Find him on Instagram, Jacksonville, as he mentioned. Check him out. Smile Icon. He has a course coming up, I believe, July, August. And I enjoy. I mean, listen, tetracycline, staining. I mean, we know this, right? When we prep tetracycline, it just gets darker and darker. And then the lab's like, listen, you got to cut so we can hide the color. And what you did is you went from a lighter color to a darker color, kind of defeating the purpose. So I thought that was a huge, at least for me. What do I know? I'm only done this for 20. But yeah, very cool. Sorry, you want to turn it down just a bit, my friend. I'm going to start yelling. I told him to play the song at the end because I just love this song, man. I can't break dance to this. I don't know where Jason is. I'm going to embarrass myself here. But anyways, next week, there he is. Next week, we have Dr. Rob Ritter from The Protocol. Really excited to talk with him. And it'll be interesting to see how he's branding The Protocol. And, you know, because I know he's got a lot going on. We're going to talk with him. But until next time, follow me at Dr. Shaheen Safarian on the social channels. Can you even hear me? Enjoy the music.